Okay. Hello everyone. Very good afternoon to all of you. So sort of starting another set of revision series, and today I would be just discussing some of the important IBQs for your upcoming NEETPG exam, right? And I will also tell you what we have in plan for subsequent revision for the next 7 to 10 days for upcoming NEETPG, right? And not only I want to cover certain IBQs, some of these have been previous year questions as well, but I would also try and cover certain important points around these topics for your exams, right? And the more you sort of interact during the session, the better it is. Try, sab karenge. If you like the session, Dr. Atik, I will have another such session. And in fact, as I said, we have planned an entire revision series for all of you, and it's called as Aag Laga, right? So, हम सब मिलकर आग लगाएंगे और एग्जाम में फोड़कर आएंगे, ठीक है? So let's start. And we will start with today's session. As I said, would love if you all contribute with the answers. Try and answer as many questions as you can around what I'm going to teach, or rather revise. And then in the end, we will also talk about strategy. Okay, we will also talk about strategy. We will talk about how to decrease your anxiety as well. So पहले पढ़ेंगे, फिर strategy की भी बात करेंगे. ठीक है? Is it good to go, everyone? Yes? Okay. So let's look at the first question as an image-based question for you, right? So do you all identify the instrument here? What is the instrument? So the instrument shown here is a vacuum extraction, right? So it's a vacuum device. Absolutely right. It is vacuum device. And let me see what all are you contributing as your answers. And you have to commit an answer. That's most important. So चुपचाप वहां बैठेंगे नहीं, सारे बच्चे अपना अपना आंसर कमिट करेंगे, so that we understand the approach and not just the answer to the MCQ. Yes, so I want each one of you in the chat box to commit your answer, because that is how we are going to learn more. Okay, good. So let's see the question. So question says, all are contraindications for the instrument shown except, right? So it's very essential, bache, that all of us learn to identify keywords in the questions. Also, when it is an IBQ, I want you all to first look at the image, okay? Look at the options and then look at the stem of the question, right? Now, the most important thing here is except, okay? So let's see what are the contraindications of vacuum extraction. So we are talking about vacuum extraction. I am sure you all know that vacuum extraction primarily is used to what? It is used to cut short the second stage of labor. Yes, so this is something you all know, but we have to convert it into MCQs as well. So is preterm a contraindication? Yes, very important. It can be a separate MCQ by itself. Yes, so preterm or prematurity is a very important contraindication for a vacuum device. In fact, at less than 34 weeks, beta, okay, at less than 34 weeks, we say vacuum is absolutely contraindicated. So prematurity is an important contraindication for vacuum device. Okay, second option. Can you apply a vacuum device in face presentation? No, okay, not at all. So the face is soft tissue. You cannot apply a vacuum extractor to soft tissue. It has to be applied on a hard base so that you can generate a negative pressure. So face presentation, is it a contraindication? Yes, okay, so this is also a contraindication. In fact, you have to remember that breech, okay, breech is also a contraindication for vacuum. So please remember, for both the two options, prematurity as well as face presentation, if at all you have to apply a instrument, what instrument are you going to apply? In preterm and face presentation. So in both these conditions, if at all you have to apply an instrument, bacha, it has to be what? Yes, it has to be forceps. right? So you can definitely apply forceps if required for preterm babies. You can definitely apply forceps for face presentation as well, okay? But you're not going to apply a vacuum device. Similarly, for breech also, you cannot apply a vacuum. Is that clear to everyone? Okay. What about option D? What about option D? D is cephalopelvic disproportion. Yes, so we are talking about all our contraindications except. So can you apply a forceps or a vacuum device when there is cephalopelvic disproportion? No. Very, very essential. Please remember CPD as well as contracted pelvis, bacha. Okay. So CPD as well as contracted pelvis, these are important contraindications for both, right? Which means they are contraindication for forceps as well as contraindication for vacuum. So please remember this, that when you talk about CPD or contracted pelvis, both forceps and vacuum are contraindicated, because the space is less, okay? So because the space is less, you can't apply another device there, right? Whereas when we talk about prematurity, or when we talk about breech, or when we talk about face, in these conditions only vacuum is contraindicated, right? Only vacuum is contraindicated. Also, please remember when we talk about breech presentation, because this can be a separate MCQ again, which forceps, bache, are you going to apply for the after coming head of breech? Can you tell me? So for after coming head of breech, which forceps are you going to apply? So it is going to be the Piper's forceps, right? So it is going to be the Piper's forceps. Please remember, for after coming head of breech, you cannot apply Wrigley's. Why? Because Wrigley's is a short forceps. Very good. Priya, Manish, excellent answers. No, Athik, not Keyland. I will tell you where we use Keyland, but not for after coming head of breech. Okay. So when we talk about after coming head of breech, bacha, we are going to apply Piper's specifically, but not Wrigley's, because Wrigley's is a short forceps. Okay. Whereas Piper's is a long forceps. In fact, it is the longest forceps, right? So please remember this. What about fetal distress? So this is the biggest confuser which I see students often land up doing wrong. Can you apply instruments in fetal distress? I want to hear what all you are going to say. Can you apply instruments in fetal distress? Yes, you can. Okay. So please remember this. When the patient is in the second stage of labor. Okay. So when the patient is in second stage of labor and there is fetal distress, provided what is ruled out? Provided CPD and contracted pelvis are not there. Okay. So provided cephalopelvic disproportion and contracted pelvis are not there, if there is fetal distress in the second stage of labor, we can definitely apply instruments, right? So we can definitely apply instruments and do a instrumental delivery. We can apply both forceps as well as vacuum. Yes, so we can apply both. Can you tell me, as per the technical answers, if there is fetal distress, which instrument is preferred? So both can be used. We can use forceps also, we can use vacuum also, right? Which instrument is preferred for it? Now conventional answers are that forceps is preferred over vacuum. Why? Because vacuum में ना आप धीरे धीरे pressure बढ़ाते हो. You cannot raise the pressure very quickly. You have to gradually raise the pressure and then deliver the baby out. But as I said, this is a technical or a bookish answer. Practically, what you and me see more in labor wards is what? Vacuum. Why? Simply because vacuum is more easier to apply. Residents are usually not trained for forceps application. Forceps needs training. So this is also actually a PYQ. Which of these is more easier to apply? What is the answer? Vacuum. So vacuum is definitely more easier to apply. And that is why clinically we see more of vacuum deliveries, but conventional answer is when we talk about fetal distress, in general forceps will be preferred over vacuum. The answer being in vacuum we gradually raise the pressure. Although the newer devices you can quickly raise the pressure. So showing the question again, so first IBQ was all are contraindications for the instrument shown except, right? So what is the answer? The answer for this question is fetal distress. Okay, is it clear for everyone? I hope there are no doubts now. So the answer here is fetal distress. Okay, now very, very important when we talk about vacuum, I also want you to know this. Can you tell me what is or where do you apply vacuum? So where would you put the vacuum device on the fetal head? Can you tell me? So which is actually the vacuum cup. Where will you apply it? So remember, when we talk about the vacuum cup, it is applied at a point which is called as flexion point, bache. Okay, it's called as the flexion point. So very, very important. It is an important MCQ as well. And do you know where exactly this flexion point is? So this is a point on the sagittal suture. Okay, so this is a point on the sagittal suture of the baby's head, which is actually 3 centimeters anterior to posterior fontanel. Yes, so it is 3 centimeters anterior to the posterior fontanel, or we say 6 centimeters posterior to anterior fontanel. Yes, is that clear to everyone? So very, very important. Remember that we are going to apply the vacuum cup at the flexion point. Why are we going to do that? So you know the newer modality of questions are that they start asking the why as well. So why do you want to apply it at flexion point? Because this ensures that the baby's head is maintained in flexion and smallest diameters are going to come out. So chances of injury to the mother are going to be less, right? So remember flexion point 3 centimeters anterior to posterior fontanel and 6 centimeters posterior to the anterior fontanel. Is that clear to everyone? Okay, very important. One more point. Can you tell me what is the pressure generated in the vacuum device that we are showing here? What is the pressure generated? Very good. Yes. So the single best answer for the pressure generated is going to be 660 millimeters of mercury, right? 660 millimeters of mercury, or please remember 0.8 kgs per centimeter square. So I want you to remember these two things here. Okay, 660 millimeters of mercury, okay, or 0.8 kgs per centimeter square. Is that clear to everyone? Yes? Yes? Yes. So 660, 600, they're all close by answers. So that's okay. Okay. So 600 or 660 millimeters of mercury, very precisely, sometimes we used to use it as 0.8 kgs per centimeter square. Okay. So that is a precise answer in kgs per centimeter square for a vacuum device. Is that clear to everyone? Yes. So 600 to 660 millimeters of mercury, it can be a range. It is absolutely okay. And 0.8 kgs per centimeter square. Is that clear? So these are some of the important things that we could ask you when we ask you about vacuum or instrumental delivery. Please remember, you must know the absolute contraindications. Yes, so we will just put the absolute contraindications one more time at one place for instrumental delivery. Can you tell me? So we discussed about cephalopelvic disproportion. We discussed about contracted pelvis. Very, very important. Third absolute contraindication is if the baby has coagulopathy. Okay. So if the fetus has coagulopathy, both forceps and vacuum will be contraindicated. And if the baby has osteogenesis imperfecta, okay. So if the baby has osteogenesis imperfecta, that is also a absolute contraindication. Okay. And then in HIV, instrumental delivery should be avoided. Okay. So instrumental delivery is to be avoided in HIV pregnancy. Now these are contraindications for both forceps and vacuum. Then yes, you're right, Pranati, when we talk about face and breech presentations, they are contraindications for vacuum, not for forceps. Okay, they are contraindication for vacuum but not for forceps. So since you all were able to answer these questions, I'll go one level higher. Okay, there is a small twist where we can confuse you in the options. Can you tell me in which type of face presentation can you apply forceps? Can you tell me in which type of face presentation can you apply forceps? So I'm just going one level higher, right? So I said face mein you cannot apply vacuum, but you can apply forceps. But which type of face can you apply forceps? So please remember this because your exams can confuse you. Yes, excellent, Dr. Sindhu, that's right. So the answer is mento-anterior beta. Okay, the answer is mento-anterior. Please remember, in case the MCQ says mento-posterior, that's where they can confuse you. If they say mento-posterior, bacha, it is becoming a contraindication for forceps also. So this means mento-posterior, you cannot apply vacuum and you cannot apply forceps as well. Very simple reason. What is the reason? Because there is no mechanism of labor in mento-posterior, right? So in mento-posterior, you're not going to apply forceps. Good to go, everybody? Should we move on to the second IBQ? Okay, if you have any doubts for the topic that we discussed so far, let me know in the chat box and I'll answer your queries. And I'm going to go on to the second IBQ for you. Yes, so let's move on to the second IBQ. Now this question says, what is the finding shown in the image associated with in the pregnancy? Yes, so can you look at the image and tell me what is it? So we have shown you fetal limbs and there are certain problems in the fetal limb. Can you tell me what is this? What is this? Anybody, any idea? So this is a condition which is called as amniotic band syndrome. Yes, so this is a condition which is called as amniotic band syndrome. I can see all of you are committing the answers. That's good. Please commit your answers in the chat box so that, you know, we learn to learn from our mistakes. In case we make mistakes, we learn to learn from them. Yes. So amniotic band syndrome, perfect. Yes, very good. Dr. Sindhu, is also called as Streeter's syndrome. Okay, so it is also called as Streeter's syndrome, and this is strongly associated with what? With severe oligohydramnios. Yes, the answer here is severe oligohydramnios. And what exactly do you see in the image? Do you see here? So you are seeing constriction rings. Can you all make that out? So you are seeing constriction rings in the baby's limbs, and these constriction rings, very importantly, as you can see, are usually present in the distal part of the limb. Can you all appreciate? In the distal part of the limb, and the constriction rings are so tight that what happens? They occlude the vascular supply to that part of the limb which is distal to it. Yes, and because that part loses its vascular supply, so that part undergoes what? Necrosis, right? And does not develop. So very, very importantly, in the Streeter's syndrome, you can see conditions which are usually going to affect the distal limbs. Now students often get confused with this and say it is phocomelia. Can you tell me what is the difference between this and phocomelia? So phocomelia, yes, is something that you should know for NEETPG. What drug is it associated with? Anybody? Phocomelia? Yes, so this is associated with thalidomide. Yes, so this is associated with thalidomide. But how is it different from streeters. So in phocomelia, what you see is proximal limb defect. It's not the distal part of the limb, it is the proximal part itself. So what you will see in the image is a baby who doesn't have an entire limb, right? So there is no limb even in the proximal part. Whereas here you see that whatever you are seeing is usually affecting the distal part, and you see digital amputation here. Can you appreciate? In amniotic band syndrome, you see digital amputation. So distal parts of the digits get amputated because of occluded vascular supply, right? So this is a strong association with oligohydramnios. Can you tell me, on the other hand, what is an associated finding in the fetus if the mother has diabetes? It has been a NEETPG. Yes? Can you tell me what would be the finding? In fact, I will show you that image in a while again. So please remember, when we talk about diabetes, does it cause oligohydramnios? No. So diabetes actually is going to cause polyhydramnios. Yes, so it is going to cause polyhydramnios. It is going to produce or cause a big baby or a macrosomic fetus. So there is macrosomia in the baby, there is polyhydramnios. Yes, we will talk about anomalies in diabetes in a while. I have a IBQ for that as well. Okay, so please remember, diabetes is associated with poly, not oligo. Yes, and who is going to tell me the cause of polyhydramnios here? Anyone? What is the cause of polyhydramnios, bacha? The cause here is fetal polyuria, right? So one of the main reasons is fetal polyuria. The other reason is high glucose content in the amniotic fluid. Right, so the amniotic fluid has a high glucose content which actually imbibes water. So that is the second reason for polyhydramnios. So first reason I said is fetal polyuria. The second is high glucose content. What could be the third reason for polyhydramnios in diabetes? The third reason can be presence of gross congenital anomalies. That can also be seen. Yes, in diabetes, and that itself can contribute to polyhydramnios. So diabetes, on the other hand, is associated with poly. Yes. What are the classic findings with antiepileptics, bacha? So antiepileptics will usually produce either neural tube defects. Yes, they will produce neural tube defects, or they will actually produce cardiovascular defects. But the single best answer for antiepileptics is neural tube defects. Yes, very good, Kashma, right? So they can also cause cardiovascular, but as I said, the single best will be neural tube. Okay, so now I'm going to ask you another question from here. So one leads to the other. If your patient is on anti-epileptics, okay, so if your patient is on anti-epileptics, can you tell me what dose of folic acid are you going to give her? If she is on anti-epileptics, what dose of folic acid are you going to give to your patient? Is it 4 milligrams? What is the answer? So please remember, the general answer for anti-epileptics is not 4 milligrams, bache. It remains as 0.4 milligrams. Okay, it remains as 0.4 milligrams. 4 kab dena hai? 4 is a very high dose. 4 is given when they specially mention drugs like valproate or phenytoin, right? So if they mention drugs like valproate or phenytoin, then yes, the dose of folic acid should be as high as 4 milligrams. Okay, but if we have not mentioned anything, it's just a general statement like anti-epileptics, then the answer is 0.4 milligrams. Is that clear? Yes, and something that we have discussed previously as well. But if there is a baby with previous history, so now they change the question. They say previous history of neural tube defects. She may now be on anti-epileptics, she may not be on anti-epileptics. Then what is the answer that you're going to mark? So yes, very good. So if there is a previous history of neural tube defects, then the dose is going to be 4 milligrams, right? So a higher dose is to be given, which is 4 milligrams. What is the dose of folic acid in a diabetic pregnancy? What about diabetic pregnancy? So please remember, the dose of folic acid in a diabetic pregnancy is again going to be 0.4 milligrams, not 4. Okay, so dose of FA in a diabetic pregnancy is going to be 0.4 bacha, not 4. Okay, so 400 micrograms or 0.4 milligrams. Is that clear? Okay, tell me this. Dose of folic acid in folic acid deficiency anemia. Yes. So if your patient has a folic acid deficiency anemia, right, where there is macrocytosis, what dose of folic acid are you going to give now? What dose of folic acid are you going to give now? Yes, very good, pals. Now the dose is going to be 1 milligram per day. Okay, so now the dose is going to be 1 milligram per day. And what is the dose if your patient is having sickle cell anemia? Anybody? So let's say if the baby has, if the patient has sickle cell anemia, then what is the answer? What is the answer? Yes. Good. So then the answer is going to be 5 milligrams. Okay, so let's quickly look at this. So we said if the question is anti-epileptics and general answer, it is 0.4. Come on, revise with me. General answer for anti-epileptics, 0.4. General answer for diabetes, 0.4. General answer for prophylaxis in all pregnant women, 0.4. Yes, so prophylaxis for all pregnant women, 0.4. But if they specially mention drugs like valproate and phenytoin, then 4 milligrams. If they mention previous history of neural tube defects, then again 4 milligrams, right? If there is folic acid deficiency, then we said 1. And if there is sickle cell anemia, then it is 5. Last question about FA. Can you tell me what is the RDA of folic acid in pregnancy? RDA of folic acid in pregnancy. So when we ask you RDA, it is going to be 500 micrograms. Okay, so it is going to be 500 micrograms or 0.5 milligrams. Okay, that is the RDA of folic acid in pregnancy. Yes, so it is 500 micrograms or 0.5 milligrams. That is why the IFA tablet distributed by the government of India actually has 0.5 milligrams. Right? I'm sure you all know that. So the iron tabs distributed by the government of India have 60 milligrams of elemental iron and they have 0.5 milligrams of folic acid. Why? Because that is the RDA of folic acid in pregnancy. Is that clear to everybody? Okay. So since we were talking about this IBQ, which is amniotic band syndrome, let's look at the fourth option as well. The fourth option here was alcohol consumption. Yes, so the fourth option here was alcohol consumption. What kind of defect would you see in the baby if the mother has been consuming alcohol? So what is the defect then that you see? Tell me. What are you going to see? So very important, we see FAS. Okay, so this is called as fetal alcohol syndrome. Okay, so FAS is fetal alcohol syndrome. Can you tell me what is the triad of fetal alcohol syndrome? What is the triad, bache? So yes, very importantly, you will see microcephaly. Yes, you will see microcephaly there. What else? Growth restriction. Okay, the second thing is growth restriction. And what is the third thing? Classic facial features. So what are the facial features that you see in fetal alcohol syndrome? There is a small palpebral fissure. Okay, there is a small palpebral fissure. What else? there is a smooth philtrum. Yes, so there is a smooth philtrum, small palpebral fissure. What else? A thin vermilion border, which means a very thin upper lip line, right? So there is a very thin vermilion border. Is that clear to everyone? So small palpebral fissure, smooth philtrum, and a thin vermilion border. Okay? So that is the triad of FAS or fetal alcohol syndrome. So classically microcephaly, growth restriction, and the typical facial features. Is that clear to everybody? Okay. Should we move on to the third IBQ? Yes? Ready everyone for the third image? Okay. What will be the association in a pregnant woman whose newborn baby presents with the following deformity, right? So tell me, what is the answer for this one? What is the association if the newborn baby shows the following deformity? I want you all to commit your answer. Yes? Commit your answer. What is the answer? What is the answer? Yes, so very correct. I think all of you are quickly answering in the chat box, and that's absolutely right. The answer will be B, diabetes. Yes, but let's approach the other options as well so that we revise some important things for the upcoming NEET PG exam. Yes, so quickly tell me, what is the finding that you see here? What is the finding? So this is actually a sacral agenesis. The other word we use is caudal regression syndrome, right? So sacral agenesis or the caudal regression syndrome. Now this is a very specific or a characteristic anomaly for diabetes, right? So please remember this. If we ask you most specific anomaly for diabetes, then the answer is sacral agenesis or caudal regression syndrome. That's the most specific anomaly. Where do you get confused? Some of you go and answer it as TGA. Okay, that's not the answer, bacha. Please remember these things. Which is the most common anomaly? So the most common anomaly in a diabetic pregnancy is going to be VSD. Okay, it is going to be VSD. When we ask you most specific in the cardiovascular system, okay, so when we ask you most specific in the cardiovascular system, then yes, the answer is actually transposition of the great arteries, right? So then the answer becomes TGA, okay, then the answer becomes TGA. And if we ask you most common finding in the cardiovascular system. Now please remember, we have only changed certain words here. Can you appreciate the change? So we are not talking about anomaly now. Earlier we were talking about anomaly. So when we say most common anomaly, it is VSD. Most specific anomaly in the cardiovascular system is TGA. But when we say the most common finding, right, then it is not an anomaly. Yes, so what is the finding? Yes, hypertrophic obstructive cardiomyopathy. Please remember, this is not an anomaly. Why? Because this is a cardiovascular adaptation of the baby's heart, right? So this is an adaptation of baby's heart. Why is this an adaptation? Can you tell me? Why is the baby showing this adaptation? Anyone? So this is because there is hypoxia in a diabetic pregnancy, right? So because there is hypoxia, the adaptation that the heart does is or undergoes is hypertrophic obstructive cardiomyopathy. What will happen after birth? The baby is no longer hypoxic. Yes. So since the baby is no longer hypoxic, will HOCM be reversible or irreversible, bache? Yes. So very, very nice. So this means this is reversible after birth. And that is why it is not an anomaly. Is VSD reversible? No, VSD is not reversible. We have to operate on it, but it cannot reverse on its own. Yes, so that is why VSD will be non-reversible, and it is a anomaly. HOCM is an adaptation, it is reversible, it is not a anomaly. Is that clear to everyone? Perfect. Very good. So remember these things: most specific anomaly, most common anomaly, most specific in the cardiovascular system. The second important thing, which type of diabetes will produce this anomaly, gestational or pre-gestational bacha? So remember that these anomalies are seen with pre-gestational diabetes. Okay, so they are seen with pre-gestational diabetes. They are not seen with gestational diabetes. So please remember this. It is very, very important. Gestational diabetes will not show you any anomalies. Okay, it is a feature of pre-gestational anomalies. Now quickly tell me, what is the cause of anomalies in pre-gestational diabetes? Anyone? What is the cause of anomalies? The reason is hyperglycemia. Okay, so the reason is hyperglycemia. So this hyperglycemia is actually fetotoxic, right? It causes free radical injury. It is fetotoxic. And that is why it causes anomalies. What happens in gestational diabetes? It happens because, in gestational diabetes, in the first trimester, usually there is no hyperglycemia. It happens later, after around 24 weeks, right? So because the hyperglycemia is happening later in gestational diabetes, which means the period of organogenesis is over. So you don't usually see gross anomalies. Is that clear? Okay. Similarly, can you tell me what is the reason for macrosomia in diabetes? What is the reason for macrosomia? So the reason for macrosomia is again hyperglycemia. So now I want to know from you, can you see macrosomia in both gestational and pre-gestational diabetes, or will you see it only in pre-gestational? Batao. Where would you see this macrosomia? Both types, pre-gestational and gestational? Yeah, only pre-gestational. So please remember this. Macrosomia can be seen in both, right? So pre-gestational as well as gestational diabetes, because in gestational diabetes also later on there is going to be hyperglycemia, yes, which in turn leads to hyperinsulinemia, and this hyperinsulinemia leads to macrosomia, right? And very correctly, this is what is the Peterson's hypothesis. So remember these important things when it comes to anomalies and diabetes. Okay, let's quickly look at other options as well. So we've already discussed thalidomide and antiepileptics. Now I want you to tell me something about radiation exposure. Can you tell me what radiation exposure, or up to what limit of radiation exposure there will be no harm to the fetus? Can you tell me up till what radiation exposure there will be no harm to the fetus? What is the answer? So up to 5 rads. Yes. So up to 5 rads, there is no damage that is going to happen to the baby. There will be no intellectual abnormalities. There will be no growth retardation, and there will be no anomalies. Is that clear? Yes. Is that clear? So up to 5 rads, there is no problem. And what does this correspond to in grays? 0.05. Okay. So 0.05 grays or 5 rads. And please remember that beyond 10 rads, it can actually cause fetal death or abortion as well. So beyond 10 rads, there is a definite evidence of severe injury to the baby. Yes. So beyond 10 rads, there is chances of severe injury to the baby. Between 5 to 10 rads, yes, what can they cause? Between 5 to 10 rads, they can cause anomalies. It can even cause intellectual abnormality, and it can also cause growth retardation. And please remember, all types of diagnostic radiation, right, will usually have a dose exposure less than 5 rads. Okay, is that clear? So whatever diagnostic radiation we are using, if she is by chance exposed to that, for example, maybe a chest x-ray, maybe a pelvic x-ray, usually the doses will be less than 5 rads for all diagnostic radiation. Okay, bacha? So they will not cause any harm. You just have to do a level 2 ultrasound for her, which is what you do for all pregnant women. Is that clear? So which is what you do for all pregnant women. Good? Okay, good to go. Should we move on to the next question? Everyone ready for the next IBQ? Okay, so I want you to commit your answer in the chat box. What is the treatment of choice for the finding shown below? Yes, what is the treatment of choice for the finding shown below? So first of all, let's try and see, are you able to recognize what it is? It is an important IBQ for your exams. Yes, so are you able to pick up? Very good. Yes, I'm seeing that most of you are committing your answer in the chat box. That's very, very good. Absolutely right. Okay, so yes, this is a very characteristic image of adenomyosis. Yes, so this is a very characteristic image of adenomyosis. And why do we say that? How do you identify? So you see a symmetrical or symmetrically enlarged uterus. Can you all appreciate? You see a symmetrically enlarged uterus. Not just that, you see areas of hemorrhage in the myometrium. Yes, so you also see areas of hemorrhage in the myometrium. So these are very characteristic findings for adenomyosis, right? The other important keywords which you have to remember when we talk is this enlarged uterus is usually soft. Okay, so we say it's a globular uterus. It's soft to touch. So when you do a PV exam, it will be enlarged symmetrically, it will be soft to touch, and it will be tender, right? So it will be a tender uterus as well. Now, when it comes to adenomyosis, can you tell me what would be the keywords in your exam if it is a clinical question? Yes, can you tell me what would be the keywords if they give a clinical vignette with this image? So you may get an image alone, or you may get it with a clinical picture. Yes, so what would be the keywords? Apart from, yes, I have shown you what would be the PV findings. The PV findings in the clinical vignette will be symmetrically enlarged uterus, which is soft to touch, which is tender, right? And yes, the size, please remember, the size will be usually between 10 to 12 week pregnant uterus size. It does not go beyond 12 weeks. It's unlikely. If it's more than 12 weeks, it's more likely to be a fibroid. Okay, so it's usually between 10 to 12 weeks. Okay, is that clear? Now please remember what would be the keywords in the clinical vignette. So very important. Your patient would be somewhere between 40 to 45 years of age, right? So she is still in the reproductive age, but towards a relatively upper reproductive age. Yes, so she will be around 40 to 45 years of age. What else? She will be coming to you with dysmenorrhea, and she will be coming to you with menorrhagia. Is that clear? So she would be coming to you with dysmenorrhea and menorrhagia. Now very, very essential. Both are important complaints of a patient, right? So both of these, dysmenorrhea and menorrhagia, are important complaints, right? Which means these are the complaints for which she'll come to us. But now let's convert this clinical vignette into a one-liner. Suppose they ask you, what is the most common presentation of adenomyosis? Then what will you answer? Will you answer it as dysmenorrhea or will you answer it as menorrhagia? So see, What we do in the exams is we ask you common topics. We can ask these common topics in the form of an IBQ. We can ask it in the form of a clinical vignette. We can ask you in the form of a one-liner, right? Or it can also be factual question which is clinically relevant, right? So what is the most common presentation? No. So the answer is not dysmenorrhea beta. Please remember this. The most common presentation is menorrhagia, followed by dysmenorrhea. Dysmenorrhea is also her chief complaint. Okay, both are chief complaints. But when we have to mark one answer, which is the most common, please understand this, it is menorrhagia. All right, heavy menstrual bleeding. That's what they usually come to us with. Yes, they have pain also majority of times, which is quite severe. Is that understandable? Now, very, very important. Please tell me, when you talk about adenomyosis, so first I'll simply give the answer to the IBQ. So the question I asked was, what is the treatment of choice for the findings shown below? So very rarely, we will tell you that the treatment of choice is a surgical procedure. Yes, but some of these places, yes, that is the answer. So when it comes to treatment of choice for adenomyosis, the answer is hysterectomy. Why? Because it is less responsive to other forms of treatment. Okay, so it is less responsive to other forms of treatment, and usually the menorrhagia and dysmenorrhea persist or even worsen, and eventually we have to do hysterectomy for these. So when we ask you treatment of choice, you have to go with hysterectomy. Is that clear? Now, coming to some important things that you should know. Can you tell me, good afternoon everyone, so some of you are joining now. So we've covered some IBQs, we're going to do some more, and then I will also talk about strategy. I will also tell you about the revision series that DAMS is coming up on YouTube and Telegram channels. Okay, so let's look at this now. So when we talk about adenomyosis, can you tell me what would be the first investigation that you would want to do if it is a clinical MCQ? Yes, so you are reading the question. Let's say they say it is a 44-year-old woman who has come to you with menorrhagia for 6 months, not relieved by NSAIDs. She has severe pain as well. What is the first investigation that you have to do? So please remember, sabse pehle, whenever we talk about abnormal uterine bleeding, especially in a reproductive age woman, you have to rule out pregnancy. Okay, so the first thing is, please rule out pregnancy. Then when it comes to which imaging modality are you going to do? So first imaging modality that we will use is going to be a ultrasound. Right? So the first imaging modality that we will be using is an ultrasound. It is going to be TVS. Don't answer it as MRI. Okay? MRI is not done in all patients of adenomyosis. So first imaging modality is TVS. Okay? But if we ask you investigation of choice, then yes, you will answer it as MRI. Why? Because sometimes TVS may not show you the characteristic findings of adenomyosis. Sometimes it might. So then you may not need an MRI. But sometimes it may not show you the findings which are specific to adenomyosis, and then you will have to do a MRI. So investigation of choice is MRI. Is that clear? Now, please never answer investigation of choice as endometrial biopsy. Some of you do this mistake. It is not endometrial biopsy. Endometrial biopsy, quickly tell me, can it diagnose adenomyosis, bacha? Can it diagnose adenomyosis? No, not at all. So, endometrial biopsy cannot diagnose adenomyosis. So, why are we doing it? We simply do endometrial biopsy to rule out other causes of AUB, like a hyperplasia, right? So we are only doing it when we want to rule out other causes like, you know what? Yes, other causes of AUB. So that is why we do an endometrial biopsy. Is that clear? So some of you actually go and mark it as endometrial biopsy as IOC. Now very quickly, because NEETPG is also fond of asking certain named signs, what are the classic findings on TVS for adenomyosis? What are the classic findings? So remember these few things. So one is Venetian blind appearance. Remember the myometrial cyst. Remember salt pepper myometrium has been a previous NEET question, right? So salt pepper myometrium and poorly defined junctional zone. Okay, poorly defined junctional zone. The cyst can also be seen just below the endometrium. So they can also be subendometrial, but very characteristic is myometrial cyst. So, okay, so myometrial cyst is very characteristic, and that's why the myometrium appears heterogeneous. Please remember the normal myometrium is homogeneous, but here the myometrium becomes heterogeneous. Okay, is that clear to everybody? Right, so I've planned up 10 IBQs right now. So today I've brought 10 IBQs. So, 10 important topics as well we are revising with these IBQs. Is that clear? Okay, so if you have any other doubt that you want to ask about adenomyosis, do let me know. We have covered the important points that you should know with respect to a clinical vignette, with respect to a one-liner, and with respect to treatment as well, or next step. Sometimes the questions are like, what is the next step? Okay, let's look at this one now. And I am sure you all know that this is a recent NEET IBQ. So what is the shaded area representing? So is it pelvic inlet? Is it mid pelvis? Is it obstetric outlet? Is it anatomical outlet? What is the answer here? Yes, so please commit your answer. Everybody in the chat box must commit their answer. What is the answer? Yes, very, very right. The answer is mid pelvis. But I have to teach you how to approach because some of you get really confused. Okay, so now let's understand this. Can you tell me why is it not pelvic inlet? So please remember, whenever we have to show you pelvic inlet, it always goes from where to where? It goes from below the symphysis pubis and it has to go to where? It has to go to the sacral promontory, right? So if it is inlet, it will be going to the sacral promontory. So it will usually go from the lower border of symphysis pubis to the sacral promontory. That's what is the pelvic inlet. Okay, somebody is asking, can a patient of adenomyosis present with infertility? Yes, they can. Okay, because a lot of times adenomyosis and endometriosis can coexist, right? So there is a possibility that patients of adenomyosis may also present with infertility. Okay, Perisai, I hope I've answered your query. Okay, so yes, infertility can be a presentation with adenomyosis, right? Hanji, coming to this, so pelvic inlet will, as I said, go from here symphysis pubis lower border to sacral promontory. Also, whenever we have to ask you about pelvic inlet, they actually give you shape of the inlet. Yes? Can you tell me which classification are they trying to ask you? So they'll show you some shape and then ask you which pelvis is this. So this classification, which is based on the shape of the inlet, is Cadwell-Malloy, right? So it is Cadwell-Malloy classification. And if the inlet looks almost circular, right? If it looks almost circular, then what is the type of the pelvis? Gynecoid. Right? So then it is going to be gynecoid. If it is a heart-shaped inlet, then you all know it is android. Sometimes, to ask you about android pelvis, they actually describe the pelvis. So can you now tell me, let me see who can tell me in the chat box. Can you tell me what other words will they use to describe a pelvis to tell you that it's android, apart from heart-shaped inlet? what keywords will they use to tell you that they are talking about an android pelvis? So very, very important. Apart from heart-shaped inlet, they will tell you narrow anterior segment. Okay. Second, they will tell you convergent side walls. Okay. So narrow anterior segment. So posterior segments are bigger than the anterior segment, obviously because it is heart-shaped. So this is the posterior segment and this is the anterior segment. So posterior are bigger than the anterior. So the other words would be convergent side walls. What else? Yes, they will say it has prominent ischial spines. So they will say that you are doing a pelvimetry in your patient. Okay, so they will say they are doing a pelvimetry in a patient, clinical pelvimetry, and they feel that there are convergent side walls, the posterior segment is bigger, there are prominent ischial spines. What else? Narrow subpubic angle. Yes, so it will also have a narrow subpubic angle. So these are few very important words that you should know. Yes, and when we read these words, we know they are talking about android pelvis. Is that clear to everyone? Yes, so then we know they're talking about android pelvis. Okay, I will talk some more things that we could ask about android in a moment. First, I'm just trying to say that in case they have to describe an inlet for you, they will rather give you a shape of it and ask you what it is. Yes. Now, yes, Jovita, I will definitely talk about occipito-posterior also, bacha. Give me just 2 minutes to complete this and then I will talk about OP as well. Okay. So now, the third shape that you have to know is antero-posteriorly oval pelvis, which means something like this, right? So AP oval, which means the antero-posterior diameters are going to be much bigger than transverse diameter. Yes, so the AP diameter will be much bigger than the transverse diameter. So what type of pelvis is this? Yes, excellent. Good going, Priya. So this will be actually anthropoid. Okay, so antero-posteriorly oval. And lastly, please understand, if we say it is transversely oval. So if we say it is transversely oval, which means the transverse diameter will be bigger than the AP diameter, right? So transverse diameter is bigger than AP. What is this? Yes, that's right. It's going to be platypeloid. So this one will be platypeloid. Okay. Now coming to what all other things they can ask you. So sabse pehle, as someone asked me to explain about OP as well, because that's what they usually ask this in combination with. So please remember, most common cause of occipito-posterior position is actually android pelvis. Okay. So the most common cause is android pelvis. All right, please remember this. The second most common cause of OP is deflexed head. And a lot of times the two things coexist as well. Okay, but the best answer is android pelvis. Now listen to me very carefully. Direct OP or persistent OP, and so many of you don't understand that it is the same thing. Okay, so direct OP and persistent OP mean the same, bacha. Okay, which means there is a short posterior rotation. Yes, so there is a short posterior rotation. Can you tell me by how much is this rotation? 1/8. Yes, so there will be 1/8 posterior rotation. When we say direct OP, it means occiput is facing sacrum, right? So it means that the occiput is facing the sacrum. Can you tell me what will be facing these pubic symphysis? What will be facing the pubic symphysis, bacha? Right. So what will be facing is face. So face is towards symphysis pubis, which means this is also same as face to pubes. Okay, which means these three words actually are synonymous. Do you understand that? Don't get confused. Please stop reading it here and there and don't get confused in the last moments of your exam. Okay, bacha? So please remember this. Direct OP is same as persistent OP. It will lead to face to pubes. So all of this are same. Now somebody is asking what is the difference between OP and direct OP. Okay, so when you say OP beta, it usually is right occipito-posterior. Okay, so the most common position in OP is ROP, right occipito. So what you see in android pelvis is actually ROP. Yes. Now when you talk about direct OP, persistent OP or face to pubes, what would be the pelvis, beta ji? It will be anthropoid. Okay, it will be anthropoid. Please don't make this mistake. Now promise that you will not make this mistake. Yes? Are you all going to promise me that? Don't make this mistake, bacha. Direct OP or persistent OP are same. They lead to face to pubes delivery and all three are seen with anthropoid. Okay? Now, let me see if you can answer this. I will convert these one-liners. Okay? So, I will convert these one-liners into a clinical question also. So, let me see if you can answer this. So, answer this question. Okay? Your question is, patient is in ROP position in labor. Okay, and after 1 hour, there is a short anterior rotation, and then there is no progress further, right? So we are saying your patient is in right occipito-posterior position, she is in labor. We examine her after 1 hour. Now there is a short anterior rotation, but after that, there is no further progress, which means there is arrest. Can you tell me what pelvis does this patient have? Can you tell me what pelvis does this patient have? So put your thinking caps on. This is a clinically applied MCQ. We have converted one-liners into clinical application. So that is what I was saying. We can ask the same question as an IBQ. We can ask it as a one-liner or a memory-based question. We can convert it into a clinical question. Yes? Excellent. And I am so happy with all of you. Very well done. So short anterior rotation means she rotates by 1/8 anteriorly and then doesn't rotate further, which means she has gone into, yes, deep transverse arrest, right? And now we are asking you simply one-liner, DTA is seen in which pelvis, right? So what is going to be the answer, bacha? Android. The best answer for DTA is android. It can happen in anthropoid as well, but the more commoner association is android. So you will not answer this as anthropoid. Some of you think it in the wrong direction. जब हम ऐसे लिखते हैं, there is no further rotation, तो आपको लगता है this has become persistent OP. This is not persistent OP. Are you clear now? Yes? Is that clear? So this is not persistent OP. Don't answer it as anthropoid. This is a deep transverse arrest. Answer it as android. Good to go? Yes? Okay. So this is explaining you why this image is not a pelvic inlet. So we simply said inlet will go from symphysis pubis to the sacral promontory. Why is this image not outlet? Why is it neither obstetric outlet nor anatomical outlet? Can you tell me the reason? Can you tell me? So very important बच्चा, कुछ basic बातें याद रखेंगे. Just like I said, in inlet it will go कहाँ से कहाँ? It will go from symphysis pubis to sacral promontory. If it is outlet beta ji, where will it go? Where will the diagram go? from the symphysis pubis to the coccyx. Yes, is that clear? Very good. Good, good, good. It will go to the coccyx. And if it goes to the tip of coccyx, then that is what is anatomical outlet. ठीक है बेटा जी? If it goes to the tip of the coccyx, that is what is the anatomical outlet. If it goes to the body of the coccyx, right, then that is what is the obstetric outlet. Yes, so if it goes to the body of the coccyx posteriorly, then that is what is obstetric outlet. Is that clear? Yes. So how would we know whether it is anatomical or whether it is obstetric? Now, converting this into an important one-liner. If I ask you obstetric outlet bacha, right, so you will tell me obstetric outlet corresponds to what part of the maternal pelvis? How will you put it as a one-liner? We can explain it in a fancy way, but if we have to convert it into a one-liner, what will you say obstetric outlet corresponds to? So please remember, obstetric outlet will correspond to plane of least pelvic dimensions. Okay, so it corresponds to plane of least pelvic dimensions. And please remember that the plane of least pelvic dimensions passes laterally kahan se? Passes through the ischial spines. Yes, is that clear? So I'll repeat, obstetric outlet, if we get it as a one-liner, not as an IBQ. So I have told you how you identify it as an IBQ. Now, if we get it as a one-liner, it corresponds to the plane of least pelvic dimensions, and laterally this plane passes through the ischial spines. Is that clear to everyone? Okay, perfect. And now, since I've told you least pelvic dimensions, can you tell me plane of maximum pelvic dimensions passes through what part? Plane of maximum pelvic dimensions passes through what part? So then you have to say disc space between S2 and S3 vertebra, right? So the plane of maximum pelvic dimensions, okay, passes through the disc space between S2 and S3 vertebra. Yes, which actually corresponds to mid pelvis. Is that clear? Which actually corresponds to mid pelvis. Yes, it is a part of the mid pelvis. It's not the entire mid pelvis. It is, but the region where it lies is definitely the mid pelvis. Is that clear? Now I hope things related to inlet, outlet and mid pelvis are clear. Yes, good to go. Should we move on to the next IBQ? Okay, so as you are good to go, I'm going to go on to the next IBQ. Okay, a very important one again for the NEETPG exams. So tell me, which of the following is not an association? So look at the keywords. Don't be in a hurry. You know everything. Okay, so please don't be in a hurry, right? So the question is asking not an association of the following Mullerian anomaly. Yes. So what is the anomaly that you are seeing here? You are seeing a uniconnuate uterus. That's right. Okay. So you are seeing a uniconnuate uterus. And how did you identify? How did you identify? Because it is banana shaped and it is deviated to one side. So banana shaped, deviated to one side is what is a uniconnuate uterus. What is the modality that you are seeing? It is an HSG film, right? So this is an HSG film showing you a uniconnuate uterus. So now, is it associated with ectopic ovary? Yes, ectopic ovary is an important association. Apart from that, please remember, uniconnuate uterus would also be associated with ectopic pregnancy. Okay, so apart from ectopic ovary, it is also associated with ectopic pregnancy, right? Now, is it associated with urinary anomalies? Yes. Okay, very, very important. Please remember, that unicornuate uterus, okay, unicornuate uterus has highest association, okay, so it has highest association with urinary tract anomalies. Now I am going to go one level further. Can you tell me on which side will you see the urinary tract anomalies? Would you see it on the side of this horn, or will you see it on the side of the rudimentary horn? Where will you see it? So, you know, this time they could ask you this. So, please remember, the urinary anomalies are usually seen on the side of rudimentary horn. Okay. So, they will be usually seen on the side of the rudimentary horn, and the rudimentary horn may be connected to the main uterus or it may not be connected. Yes, so it may be connected or it may be blocked. Okay, both things are possible. Now, can you see endometriosis? Yes. So, because one side can be blocked, there may be a possibility of outflow obstruction and a more of retrograde menstrual flow. In fact, you have to remember that all Mullerian anomalies, okay, all of them can cause endometriosis. Okay, so very important. They may ask you what is the cause or what theory explains this. Can you tell me what theory? So, whenever we ask you what theory explains endometriosis in a certain condition, the best answer is always going to be retrograde menses, which is what theory? Sampson's, right? So, retrograde theory is actually the Sampson's theory. The only place where you have to be very cautious, because I am trying to go one level ahead as well. These things are very commonly asked, right? One level ahead, and let me see who can answer. So, now I am asking you, your patient has Mullerian agenesis. Okay, not an anomaly, but Mullerian agenesis. Can she have endometriosis? I want to ask you this. Can she have endometriosis? Yes or no? Let's see who can answer. So, patient has Mullerian agenesis. Can she have endometriosis? Okay, so as I said, just a little tricky and we are going a level higher. So, the answer is yes. Even Mullerian agenesis can have endometriosis. The theory here is coelomic metaplasia or ectopic Mullerian tissue. Okay. So, please remember this, that even Mullerian agenesis can have endometriosis, but the theory will not be Sampson's theory or retrograde menses. Okay. So, please remember here it is going to be coelomic metaplasia or ectopic Mullerian rests. Is that okay? No, JJ, this is not the same session as PYQ ka baap. Here I am only discussing some important IBQs, and with those IBQs I am discussing some important topics that can be asked, right? So, ectopic Mullerian rests, which means Mullerian tissues are present elsewhere. So, either they convert into Mullerian tissue, which is coelomic metaplasia, or they may be present at ectopic sites and then develop endometriosis. Okay? Is that clear? Okay, perfect. Now, so what is the answer here? The answer is transverse lie. So, let's look at the question again. So, this is not an association with the following Mullerian anomaly. The answer is transverse lie. The reason is very simple. Because of small space, the baby cannot go into transverse positions. Can it go into breech position? Yes. So, please remember, it can still have malpresentations, but which malpresentation are you likely to see here? Breech. Okay. So, the malpresentation that you are likely to see in a uniconnuate uterus is actually a breech malpresentation. Is that clear to everyone? The same thing holds true for uterus didelphius, right? So please remember, even uterus didelphius, breech malpresentation can happen, but not transverse lie, okay, but not transverse lie. Quickly, just ensuring that you know these one-liners. What is investigation of choice for Mullerian anomalies, bacha? So remember, investigation of choice for Mullerian anomalies is a 3D ultrasound, okay? It's a 3D ultrasound, right? The gold standard, which means in case 3D ultrasound cannot make a diagnosis, which is quite rare, then we would order a MRI. So MRI is not done for all patients of Mullerian anomalies, okay? And if we ask you best procedure to confirm diagnosis, okay, best procedure to confirm diagnosis, which means none of these radiological investigations are helping us, we are still in doubt, then we have to see it ourselves. So that will be a laparoscopy plus hysteroscopy. Now listen to me very carefully. Kabhi kya hota hai, lap and hystero are not given together, they are given as separate options. What will you mark if they are also separate options? Then what do you do? So always, if you have to pick one of them, it has to be laparoscopy. Why? Because to know what anomaly it is, you have to see the fundus of the uterus. If you can't see the fundus, you cannot make a diagnosis. So hysteroscopy alone will not be helpful in diagnosis. Is that clear? Hystero alone cannot make a diagnosis. It can in fact not differentiate between septate and biconjugate also. Is that clear? So if you have to differentiate, you need to see the fundus. So if you have to select one of them, you have to go with laparoscopy. Is that clear? Okay, good to go. Should we go on to the next IBQ? Should we go on to the next IBQ? Okay, this is a very simple one, but I just want to ensure that you know certain points around this, because this has been a PYQ as well. So what is the ideal time to look for the finding shown in the image below? Yes? So what is the ideal time to look for the finding shown in the image below? Yes, Indian, I will upload the same PDF in the Telegram channel of DAMS. So official DAMS-eMedicoz Telegram channel, I will upload the PDF for all of you so that you can go through it. Okay? Hanji. So what is the time? The time is 11 to 13 weeks. That's very right. So this is 11 to 13 plus 6, right? So that is the ideal time to look for NT. Now please answer the following questions, because they can be asked in the exams and they're very scoring questions. So when you say increased NT, what is the cutoff we take? More than or equal to 3 mm, right? So the cutoff we take is more than or equal to 3 mm. Now tell me, what should be the next step if NT is increased? Can you tell me? What should be the next step if there is increased NT in your patient? Anyone? So A, is it NIPT? B, is it a dual test? C, is it CVS? Or D, is it amnio? Right? So let's see if you can answer this. So I am saying that in your patient, this patient, the NT turns out to be more than 3 mm. What should be your next step? Is it a NIPT, non-invasive prenatal test? Is it a dual test? Is it chorionic villus sampling, or is it amniocentesis? Commit your answer. A, B, C or D. What is the answer for this one? So the answer is C, chorionic villus sampling. Okay, so please remember, increased NT has high association with aneuploidy. Therefore, the best thing to do after this is karyotype confirmation. And because she is still in the first trimester, when you are doing NT, you are not going to wait for amnio, because amnio is beta G done in the second trimester. Now I want to do a confirmatory test in the first trimester. So what would be the answer? Again, a very silly mistake, but yes, we do land up making it. So it's not amnio beta G, it is going to be chorionic villus sampling. Yes. Now, answer some other questions. Can you do NIPT also? Yes. If a patient does not want to undergo an invasive test, then NIPT can also be done. So, NIPT is an alternative. Okay. So, NIPT is going to be an alternative test, but not the best test. The best is to follow up with chorionic villus sampling. Now, quickly, I want you to know the time periods of these tests also. So, you are going to answer these important questions for me. When do you do NIPT? Anybody? So, NIPT can be done any time beyond 10 weeks, not before 10 weeks. Okay, not before, because you will not get any specimen of cell-free fetal DNA. So, basically, we are looking for cell-free fetal DNA in maternal blood. So, if you do it at less than 10 weeks, this sample is going to be very small. You will not be able to do any test. So, you do it beyond 10 weeks. When do you do dual test? The second option was dual test. So, when do you do the dual test? So, dual test is again done anywhere between 10 to 13 weeks. Okay, you can do it anywhere between 10 to 13 weeks. What are the parameters? The parameters are HCG and PAP-A. Okay, where HCG will be higher and PAP-A will be less than expected. Yes. Most commonly, yes, we do it between 11 to 13 because we call the patient at that time, we do a dual test also and we do an NT scan also. But it can be done any time from 10 to 13 weeks. Okay. What is a combined test, bacha? So, combined is dual plus ultrasound for NT. Okay. So, that is what is a combined test, which means it is a first trimester test. Okay. So, that is what is a combined test. Now, when do you do amniocentesis? When do you do amniocentesis? And when do you do CVS? So, please remember, CVS again can be done any time from 10 to 13. But most commonly, we do it between 11 to 13. The reason is because it is a follow-up test after a dual test or an NT scan, right? So, it can be done any time from 10 to 13, but most commonly between 11 to 13. What about amniocentesis? Amnio can be done anywhere after 15 weeks, but most commonly we do it between 16 to 18. Why most commonly between 16 to 18? Because amnio is usually a follow-up test for which one? It is usually a follow-up test for quad test. Yes, and quad test is generally done between 16 to 18 weeks most commonly. Can be done. So please remember, NEETPG वाले बहुत specifically पूछते हैं and you have to know the entire window. Quad test has been a PYQ as well. So please remember, actually quad test can be done anywhere from 15 weeks to 22 weeks, right? So anywhere from 15 to 22 we can do a quad test. Is that clear? Perfect. Okay. So if the quad test is deranged, which is HCG, UE3, alpha fetoprotein and inhibin A. Yes, and I'm sure you remember the changes. HCG and inhibin A, it is A, not inhibin B, are raised, and UE3 and alpha fetoprotein are less. Okay, so that is what is the quad test. So if the quad test is high risk, okay, and then we ask you what is the next step, then what will be your answer? Quickly tell me. So that we cover all types of questions, yes, so that we cover memory based questions, we cover next step questions, we cover clinical vignettes, we cover IBQs, yes. So what would be the next step, bacha? Yes, very good. Now the answer cannot be CVS. Okay, now the answer has to be amnio. Right? So now the answer has to be amniocentesis. Okay, last question before I go on to the next IBQ. What is early amniocentesis? Do you all remember? We've done it in the classes. What is early amniocentesis? When it is done between 11 to 14 weeks. That's when we say that it is early amnio. It's no longer done in modern obstetrics. Yes, but this is what is a early amnio. Is that clear, bacha? Okay, good to go. Should we move on to the next IBQ? All right. So I think we are left with 2 more. So a total of 10 IBQs and 10 topics is what I am discussing now. Okay. So let's look at this. The following ultrasound image is characteristic to which ovarian mass? Can you tell me what image is it? Can you identify the image? Okay, Aman, simply remember beta that HCG, I'll write it there itself. So when we talk about quad test, Aman, remember HCG in Downs is always high, right? And apart from that, only inhibin A is the other parameter which is more. Everything else is less. Okay. So remember, HCG and inhibin A are the only 2 parameters which are higher than expected. All other parameters, whether it is PAP or UE3 or AFP, they will be low beta. Okay. Hanji. So what is this image? So bache, this is a image of a sign which NEETPG asked only as named sign. They didn't give you the image. They asked you the named sign. What I have done is, I have brought the image of the named sign. What is this? Okay, Ruchita, NIPT bache stands for non-invasive prenatal test. Okay, so NIPT stands for non-invasive prenatal test. Why? Because all we are doing is collecting a sample of the maternal serum, okay, maternal blood. Yes, very good, Atik. Good, good, good. So this is an ultrasound image which is showing you the dot dash sign. So this is what is the dot dash sign. Can you tell me what is this sign seen in which ovarian mass? So it's a very characteristic sign of dermoid. And why is this sign there? Because of the presence of hair follicles in our dermoid. So because of the hair follicles, they give this dot dash sign on ultrasound. Okay. Now very, very important. Do you know what other important name signs you should know for dermoid? Because NEETPG sometimes does ask only the name and then nothing else. So what else can you tell me are the named signs? So I'm sure you have all heard of tip of iceberg sign. Yes, tip of iceberg sign. This is also an ultrasound sign of dermoid. Then, yes, Rokitansky protuberance is also a sign of dermoid. So please remember that these 3 are very important. Okay, dot dash, tip of iceberg, Rokitansky protuberance. If you can't remember more, at least remember these 3. Okay. Now, when we talk about dermoid, please remember this is the most common ovarian tumor in reproductive age. And this is why it also becomes the most common tumor in pregnancy. So the most common ovarian tumor that you see in pregnancy will also be a dermoid. What is the full form or other name for dermoid? Yes. So more than mature teratoma beta, I want you to remember the entire name. It is mature cystic. So most of this ovarian dermoid is going to be cystic in nature, with only one area which has a brighter image on ultrasound, which is the Rokitansky protuberance. So most of it will be black. Only a part of it where the normal ovary and the dermoid meet, that's where you will see the Rokitansky protuberance, right? So this is a mature cystic teratoma. Okay, remember the name. Is it benign or malignant? So please remember it is benign. Okay, so it is mostly benign. Can you tell me, if I say it is always benign, will that statement be true or false? So suppose in the NEETPG exam, they say it's always benign. So true or false? False. Whenever you see this word always in medical science, it is false. It's not always benign. The risk of malignancy is around up to 2%. Okay, so it ranges from 0.2 to 2. So that is the risk of malignancy in a dermoid. It is a rare event, but it can happen. And if it does, it will be a squamous cell cancer. Okay, it will be a squamous cell cancer. And which area will this malignancy arise? Rokitansky protuberance. Okay, so it will appear in the Rokitansky protuberance. So that is the area where, if at all there is going to be a malignancy, it will happen. Okay, very importantly, dermoid is unilateral or bilateral? Because I see students making that mistake. Unilateral or bilateral, bacha? Tell me. So please remember, majority of times when we say germ cell tumors, so dermoid is an example of a germ cell tumor, majority of times they are unilateral. Okay, so mostly dermoid is unilateral. That's what your answer is going to be. Okay, always. But if they specially ask, can it be bilateral? Then yes. So in up to 10% cases, it can be bilateral as well. But majority of times you have to answer it as unilateral unless they ask directly what is the percentage of bilaterality. Yes? Okay. Now, also remember 20% is the answer for dysgerminoma beta, not for dermoid. Dysgerminoma can be bilateral in up to 20%. Okay. Now, very, very important. Please remember that dermoid can undergo torsion as well. So, most common ovarian tumor to undergo torsion. And that is why whenever we come across a dermoid, we want to remove it. So remember, if you see it in a patient where family is not complete, what treatment will you do? Cystectomy. Okay, you will be doing a cystectomy. But can you do an oophorectomy as well? Yes. So if the family is complete, we can also do a oophorectomy on that side. Is that clear? It can be done because yes, there is a possibility of recurrence as well. So if the family is complete, we can do a oophorectomy as well. So these are some of the important points that you should know about a dermoid, right? So they are likely to be asked, they have been previously asked. Even if you don't remember rare things, these are must knows. Okay, good to go. Should we go on to the next IBQ? Okay, so I think this is the second last IBQ. So as I said, I brought 10 today to discuss 10 topics and a rapid revision. So let's look at this one. So what is the diagnosis in a woman with infertility and the following ultrasound image during infertility treatment? That's an easy one, but it's an important MCQ for NEETPG. Yes, very good. So all of you unanimously are committing that this is ovarian hyperstimulation syndrome. Now I want to know from you, why is it OHSS? Can anybody tell me why? You're all correct. It is ovarian hyperstimulation, but why is it OHSS? So because there are big follicles and less stroma. Can you all appreciate? The size of the follicle is very big. The stroma is less. Please never confuse this with PCOS. In PCOS, it's reverse. Follicles will be small and stroma will be more. There is actually stromal hyperplasia. The stroma is where you see the theca cells. That's where the androgen is coming from. So don't confuse this with PCOS. Okay. Second important thing. when we ask you, this is an image of simply a hyperstimulated ovary. Okay, this is actually not a syndrome because we haven't given you any symptoms. We are just showing you an image. So this is a hyperstimulated ovary, right? Can you tell me, in case they show you the image and ask you which drug, so now I'll change the MCQ. They will say that a woman is undergoing infertility treatment and the following ultrasound image is seen during the infertility treatment. Which drug has she received? Right? So, which drug has she received? I am changing the question. Okay, they show you this image and they ask you which drug has she received. It's the same thing, but the question changes. Your options are A, is it HMG? B, is it letrozole? C, is it HCG? Or D, is it GnRH? Can you tell me what is the answer? So, which drug has your patient received such that the ovaries are showing you this kind of an image? So, commit your answer, commit your answer. So, that's where some of you start getting confused. So, a lot of you are answering it correctly, but some of you are answering it incorrectly as well. So, please remember, the drug which is causing this hyperstimulation of the ovary is HMG beta. It is not HCG. HCG is not stimulating the ovary. It is HMG which is stimulating the ovary. Human menopausal gonadotropin. Okay. And when you say that, what do you exactly mean by this? It means injection FSH. Right. So, they may not write HMG. They may write FSH. That's the answer. HCG क्या करता है? HCG doesn't cause this big ovary. It causes the syndrome. What happens once you have given FSH and it stimulates the ovary to this size? Now, when you give injection HCG, the follicles will rupture. When they rupture, they release fluid which has inflammatory mediators and then the syndrome happens. So, I wanted to specially tell you this because I feel some of you are very confused. I hope I have made it clear. Do you understand? So, आपने पहले HMG दिया, yes, या FSH दिया, जिसने ovary को stimulate कर दिया और ये image produce करी. This is a simple hyperstimulated ovary. Okay? लेकिन इसमें कहीं नहीं लिखा है कि patient को कुछ symptoms हैं. ठीक है? So, patient को अभी कोई syndrome नहीं है. अभी क्या है? Now, if I say she has also developed ascites, she has developed breathlessness, abdominal pain. Now, if I ask you what is causing these symptoms, now what will be your answer? Tell me. Now, the answer will change, beta ji. Now, the answer becomes HCG because the symptoms are not produced by FSH. ठीक है? The symptoms are produced because you gave HCG which caused rupture of the follicles. The fluid was released which has VEGF which will cause these symptoms. ठीक है? अब clear है? Good to go everyone. Please ये गलती दोबारा नहीं करोगे. खाली image पूछा है, कुछ भी आसपास नहीं लिखा है and they are asking you कौन सी drug मिली है. It is HMG, FSH which has stimulated the ovary. ठीक है? So, please remember, the syndrome of OHSS is caused by HCG. Which was the mediator which is resulting in these symptoms? The mediator is VEGF, vascular endothelial growth factor. Is that clear, bacha? Clear to everyone? I hope you will not make this mistake. Now, remember, when you see such big ovaries, this is multifollicular development. Do you all agree? So, if it is multifollicular development, can it be caused by letrozole or GnRH? Never. Okay. So, no, multifollicular development is not caused by letrozole. It is not caused by GnRH agonist. okay, they will cause monofollicular development. ठीक है बेटा, तो इसीलिए इस क्वेश्चन का आंसर cannot be letrozole, cannot be clomiphene, cannot be GnRH. Okay, clomiphene क्या करता है? It will cause some more follicles, but not so many, right? So clomiphene can at the max cause twins. So there are some more follicles, but not so many. If you are seeing so many of them, it cannot be CC, it cannot be letrozole, it cannot be GnRH. ठीक है बच्चा? Is that clear? Yes. Because letrozole is causing monofollicular development, that is why it is the drug of choice for ovulation induction in PCOS. Is that clear? Yes. Now, I just want to ensure that we have no doubts. Suppose I ask you, my patient is a case of PCOS. I'm giving you a clinical question now. I've done the IBQ, I've done the one-liners. Now I am discussing only a clinical question with you. Ready for the clinical question? Okay. So I am saying your patient is a known case of PCOS and she has infertility. She has not conceived, okay, so far, okay, and you are now planning, okay, so she has not conceived and you are now planning IVF for her. Which drug do you want to give her? Answer this question. Which drug do you want to give? Do you want to give A, CC, B, letrozole, C, HMG, or D, GnRH? So I am saying your patient is a known case of PCOS and she has infertility. She has never conceived. She is now planning IVF. Which drug do you want to give her? Tell me what is the answer. Now, kuch bacche, again, see, I have taught you it right now, but you are doing the same mistake. Now, please remember, you are doing such an expensive procedure for her, IVF. It is going to cost her a lot of money. Do you want that only one follicle should develop? Do you really want that? Tell me. Do you want that with such expensive treatment, eventually she lands up with only one follicle and then, you know, poor thing, there'll be only one embryo and that might not implant? Yes, so do you see how understanding concepts is very important rather than mugging up one-liners? So even if you have sort of mugged up, drug of choice is letrozole, drug of choice is letrozole, chanting से concept नहीं clear होते और ना उससे confirm होता है कि exam में answer सही होगा कि नहीं. समझ रहे हो? So please understand this. You have to understand more than chanting. ठीक है? So if you are doing IVF, I don't want one follicle. I want many follicles so that I am able to make more embryos so that the chances of conception are higher. ठीक है? So whenever the question is about IVF, please do not mark CC and letrozole. ठीक है? Is the concept clear? So when we talk about IVF, I want to make many follicles so that chances of conception are higher. So now the answer will again change and it will become HMG. ठीक है? Good to go everyone? The concept is clear? Because CC will not produce so many follicles बच्चे. CC तो कभी कभी सिर्फ 2 follicle बना देती है. ठीक? That is why at the max उसमें twin हो सकता है. With HMG you get many follicles. ठीक है? अच्छा, एक और convert करूँ. I will convert the same concept and now let's see if you can answer. Okay? Just to ensure that you've got the concept right. So now the question is, your patient has undergone an infertility treatment. Okay? So your patient has undergone an infertility treatment and she is now pregnant with quadruplets. What drug did she receive? Again, the options are same. The options are same. Okay, your patient has undergone an infertility treatment and now भगवान की जब देन होती है तो बहुत सारी होती है. So now she is pregnant with quadruplets. Can you tell me what drug did she receive? Yes. So the same concept. Do you understand this? So when I teach you a concept, I can convert it into an IBQ. I can convert it into a one-liner. I can convert it into a next step question. I can convert it into a clinical vignette. It doesn't matter. If your concepts are good, you will be able to answer any which way. Yes. अरे बाबा अभी लेट्रोजोल नहीं हो सकता, क्वाड्रुप्लेट्स लेट्रोजोल से नहीं हो सकते बेटा, अभी तो मैंने सिखाया. ठीक है, क्लोमीफीन मैंने बोला अभी, आई जस्ट सेड आदित्य बेटा, क्लोमीफीन एट द मैक्स कैन प्रोड्यूस ट्विन्स. Higher order gestation, okay, higher order gestation, triplets, quadruplets and so on are produced by HMG. ठीक है जी, clear to everybody? All right, moving on to the last IBQ for the day. And last में हमेशा lollipop question. Yes, an easy one to boost your confidence. Okay, quickly so that we can then talk about the revision series that DAMS is planning for all of you, and we can also talk about some of your doubts. Right, so a 25-year-old woman is presenting to us with a lower abdominal pain and the following ultrasound image is seen. What is the likely diagnosis? Yes, so what is the likely diagnosis? Yes, so this is the classic appearance and you will not do it wrong, okay? So this is the classic appearance of chocolate cyst, which is also called as what, bacha? It is also called as endometrioma. And what is this classic appearance? It is a cyst, matlab black background hai, or uniform white deposits hai. So we say it has homogeneous internal ecos. Right, so homogeneous internal ecos, and this is what is called as ground glass appearance. Gunpowder nahi bacha, ground glass. Okay, so ground glass appearance. There are homogeneous internal ecos. So this is a chocolate cyst or an endometrioma. Okay, let me ask you, what is the treatment of choice for her? Now I am changing the question. The image is same, MCQ is almost same. Instead of asking you what is the diagnosis, I am asking you what is the treatment for her. So a 25-year-old girl comes with a lower abdominal pain, the following ultrasound image and following finding. What are you going to do? Very good. Yes, so because the cyst is symptomatic, and whenever it is symptomatic, we must do what? A cystectomy. Okay, so treatment of choice for symptomatic chocolate cyst or cyst which may be asymptomatic but is bigger than 5 centimeters. So if it is asymptomatic but it is bigger than 5 centimeters, or if it is symptomatic, we need to do a cystectomy. Do not mark incision and drainage. Do not mark cyst ablation because these have a high recurrence risk. So treatment of choice is surgical. Do not mark medical management. Endometriotic cyst or chocolate cyst does not respond to OCPs, does not respond to progesterone, does not respond to medical management, right? So the answer is surgery and we will do a cystectomy. Okay, now I want to ask from you, if your patient has a chocolate cyst, is it considered as severe endometriosis, minimal endometriosis or mild endometriosis? What is it? So this is severe endometriosis. Okay, it will be severe endometriosis. And please remember, if this girl is also having infertility. So they say she has a chocolate cyst, she has infertility, right? What would you do for her? So please remember, now the answer is not cystectomy. Please listen to me very carefully. Okay? The routine answer was cystectomy when it is symptomatic. Now here it says she simply has a chocolate cyst, she has infertility. What are you going to do? So this means it is severe endometriosis, and management for infertility with severe endometriosis is IVF. And routinely, okay, listen to me carefully, routinely chocolate cysts are not removed before IVF. Is that clear? Because they reduce the ovarian reserve, or there is a possibility that you will damage the follicles. So routine removal of chocolate cyst before IVF is not done. Is that clear to everybody? Yes? In vitro fertilization, that is the treatment for moderate to severe endometriosis and infertility. Is that clear? Okay, so this is important things that you should know about chocolate cyst and endometriosis. Please remember, investigation of choice for chocolate cyst. What will you answer? Let me see, because I think here again certain bachas can make mistake. What is the investigation of choice for chocolate cyst? Please don't answer laparoscopy. See, investigation of choice for endometriosis is laparoscopy. But when we say investigation of choice for chocolate cyst, you don't need a laparoscopy, you only need an ultrasound. Okay? So please, ये common mistakes हैं जो overthinking से हम करते हैं. So no overthinking in the exam. If it is an adnexal mass, the investigation of choice is TVS. Is that clear, bacha? Okay? We don't even need an MRI. A ultrasound is good enough to pick up a chocolate cyst. If there is a doubt, then yes, I can do an MRI as well. Okay? Is that clear? Perfect. So these are some of the important IBQs. Okay. So as I said, I brought 10 IBQs today. A lot of them were PYQs as well. And I tried to discuss 10 high yielding topics. Now quickly telling you our plan or DAMS plan for revision close to NEET exam. So we are going to conduct YouTube live sessions as well as Telegram sessions. So ensure that you are subscribed to both these channels, DAMS Delhi YouTube channel as well as DAMS-eMedicoz Telegram channel. We will be conducting live sessions on both these, and the session is called as Aag Laga Do. Okay, so आग लगाएंगे, रिविजन करेंगे, एग्जाम में फोड़ कर आएंगे. ठीक है? आग लगा दो सेशंस will be held on YouTube for next 7 days at 7 p.m. Okay, at 7 p.m. YouTube live sessions where teachers will be coming live. We will keep it as a 2-hour live session so that you get your time of revision as well. Okay, I will talk about free mock also mediastrum. Just give me a minute. Okay, so Aag Laga Do 7 p.m. sessions on YouTube and 9 p.m. sessions on Telegram channel. Yes, in the Telegram you can also ask your doubts from the previous YouTube session. So you can ask any doubt. We want to keep it interactive. Yes, आज मैं आई थी श्रुति आग लगाने. Okay, just to inform. But yes, from tomorrow we will start these sessions. ठीक है? That is why I actually came today, so that not only will I sort of teach you or revise with you for some time, but also tell you about the upcoming plans that DAMS has. Okay, so please remember, Telegram पे रात को करेंगे 9 से 11 and YouTube live at 7 p.m. Okay, interactive, you can ask your doubts in both these channels. Also, I am telling you, whatever we will do live, the PDF will be uploaded on the Telegram channel. So even the today's class PDF, I will upload on the DAMS-eMedicoz Telegram channel. So please subscribe today. I will share the link of the Telegram channel later in the comment section as well. So all the PDF of the YouTube live sessions that we will do will be uploaded on the Telegram channel so that you can quickly flip through and revise if you feel a particular subject is weak or certain topics you want to revise in a fast mode, right? We want to keep it concise, crisp, high yielding. That's what is the motto of DAMS. We don't want to run a whole day session. So we want to keep it concise, crisp, high yielding so that you have a good strike rate, when you want to revise important topics, right? So please remember, no, Indian, I have only covered 10 IBQs today because I've also covered those 10 topics, right? If you like the session, you can let me know. I will hold another such session, but we need to revise all subjects. Yes, we can't be only revising Obs Gyne. Okay? So, if you like this session, please let me know. I will plan another one with 10 more IBQs and 10 more topics. Please understand, all other faculties are not going to do IBQs. They will choose, okay? So we let the faculty decide what they want to revise because they are the best judge of what is likely to be asked in the exam, right? So all types of things which the faculty feels are important or most high yielding will be revised, okay? One OBGY session every day, तो बाकी subject कब पढ़ोगे? I'll come again. It is a pleasure to teach you and especially to teach live on the app or on YouTube, and even more pleasurable in the face-to-face classes. But yes, I will definitely plan another one. But the Aag Laga those sessions will start from tomorrow 7 p.m. YouTube live as well as Telegram live sessions. You can ask your doubts, you can accumulate your doubts and then ask us, okay? Thank you so much, Shama Rateria. That's very, very kind of you. Yes, I will bring in one more session. So kind of you. I will definitely be there. Okay. So today's PDF, I will also get it uploaded on the Telegram channel of DAMS so that you can revise. And then strategy अभी के लिए बहुत simple रखेंगे. ठीक है? Simple strategy क्या है? Let's revise in a fast mode. Okay, let's revise in a fast mode. Let's revise common things. Let's revise multiple times, right? Especially for topics that you are weak in. So if you feel that आपका कोई topic weak है, and how do you know that? Because you are giving tests. So आपने CBT दिया, you are giving grand test also. Please ensure that you are making a list of topics that you have done wrong, and the topic list has to be very, very specific. Okay? Make that list and try and revise that, only that part of the topic, not the entire chapter, only that topic in a fast mode from your class notes. Okay? So abhi ka strategy is something that I would do if I was in your place. I will give a test, I will do an analysis, and I will revise DVT booklet. Okay, it is a must-do resource, especially in the last 7 to 10 days. Test, analysis, revise. Test, analysis, revise. You only have to do this now. Please don't go after uncommon, rare, unique things. Okay? They fetch you unique ranks. Okay? So test thingy, try and give it every 3rd or 4th day. Do an analysis, which means make a list of topics, okay, that you have done wrong, और फिर उसको revise करो. ठीक? Now please understand one thing. Anxiety एक level तक अच्छी होती है because it helps you go harder. So some amount of anxiety is good for performance, but don't let it affect you so much that your D-Day performance goes down. Whenever you feel you're going overboard with anxiety, you have to tell yourself that I am good enough. I have worked truthfully. Yes, these are a few things that we have to keep telling ourselves. One, I am good enough. Okay, I may have a lot of flaws. Okay, I may not be the best person on earth, but I am good enough. That is the first thing you tell. Yes, we will put up the entire revision schedule on the YouTube channel in a poster. We will share it on the Telegram group as well. The entire YouTube live Aag Laga session schedule will be put up for you, okay, beforehand. So one, you have to tell yourself, I am good enough. Second, I am working truthfully. Usse kya hote hai na? When you are not even working truthfully, it is a reminder that set your priorities right. Stop going on the social media platforms. Focus in your work. Don't look here and there. Don't talk to everyone. Okay? So tell yourself, I am good enough. I am working truthfully. And I am in it to win it. There is no other plan B. There is no other outcome. There is only one outcome, that I will win. Okay? These are the only three things that you have to tell yourself. Will you all tell yourself these three things? Because you know, I've seen that there are a lot of people who will be doubting you. But you can't doubt yourself. Right? So you can't doubt yourself. You have to be confident with what you have and with what you are, and then march forward. Okay? Yes. PYQ ka BAP session is very, very important. If you have done it live, no need to do it again. But if you haven't seen it, then yes, all the PDFs of PYQ ka BAP are uploaded. Those are annotated PDFs, right? So you can go back to the PDF and quickly flip through. The questions will be put in the DQB format as well for you to practice again if you want. Okay? Mock test is the last thing that I'm coming to. Yes, so we are making a free mock test for all of you. I will announce the date soon, either today or tomorrow. So we will come out with a mock test for all of you, right, which will be free for all, and anyone can give it on the app, on the NEETPG app. Okay, so we will definitely have one mock test for you. I'll announce the date very soon. Okay. Mediastinum, the questions will be put within the PYQ ka BAP course itself. They will be put in the DQB format so that you can test or practice the MCQs there. Yes. So this is it from my side. But tomorrow you will have Aag Laga session at 7 PM YouTube live DAMS Delhi channel. There are a lot of other announcements that DAMS is coming up with. Stay tuned, and we will ensure we bring the best to you from our side, right? So all of you, remember, I am good enough, I'm working truthfully, and I'm in it to win it. God bless everyone. See you again, and I will come back with another session to revise. Okay? Take care everyone. Bye.